Angina and myocardial infarction, Pathophysiology, Diagnosis, Treatment, and Patient Education by John Willoughby. Angina and myocardial infarctions, or MIs, are critical conditions that reflect underlying cardiovascular disease, the leading cause of death worldwide. Angina is a symptom of ischemic heart disease, characterized by chest pain or discomfort due to reduced blood flow to the heart muscle. It often serves as a warning sign for more severe heart conditions, including myocardial infarction. Myocardial infarction, commonly known as a heart attack, occurs when blood flow to the part of a heart is completely blocked, leading to the death of heart muscle tissue. This can result in significant morbidity and mortality if not treated promptly. These conditions are significant in cardiovascular health because they highlight the importance of early detection, risk factor management, and prompt treatment to prevent severe outcomes like heart failure or sudden cardiac death. Understanding angina and MIs are crucial for clinicians, as timely intervention can save lives and improve long-term health outcomes. What is angina? There are a couple different types of angina. There's stable angina, also known as typical angina or angina pectoris, which is Latin, is a symptom of myocardial ischemia. It's characterized by chest discomfort or anginal equivalent, provoked with exertion and alleviated with rest or nitroglycerin. Typical angina is often described as pressure-like heaviness, tightness, or squeezing. It is most commonly affecting a broad area of the chest rather than a specific spot. There may be radiation of the pain depending on which dermatomes are affected, sometimes down the left arm, up the left neck, into the left jaw, but it can also happen to the right side as well. Unstable angina is when chest pain will not improve with nitroglycerin and/or rest. The most common cause of unstable angina is due to the coronary artery narrowing due to a thrombus that develops on disrupted arteriosclerotic plaque and is non-occlusive to the artery. Prinzmetal's angina. Prinzmetal's is when a vasospasm occurs in the coronary artery, also known as a vasospastic angina. It is characterized by chest pain at rest with transischemic ECG changes in the ST segment, but quickly responds to nitrates. The pathophysiology is, simply put, angina results from an imbalance between the myocardial oxygen supply and the myocardial oxygen demand. It is caused by the narrowing of coronary arteries due to arteriosclerosis, also known as coronary artery disease, or CAD. What does angina feel like? The descriptors are generally tightness, squeezing, heaviness. Location, typically in the sternal area, maybe right behind the sternum, may radiate to arms, neck, jaw, or back. Associated symptoms can be shortness of breath, nausea, fatigue, dizziness. Triggers can be physical exertion, stress, or cold exposure. You can use old charts to figure out the pain level, onset, location, duration, characteristic, alleviating and aggravating factors, radiating or relieving factors, timing or severity. Also, they can use OPQRST, which is roughly the same thing, onset, pain or palpitation, quality, radiation, severity, and then the time. Common signs and symptoms of myocardial infarction. Elderly patients can have silent MIs just due to advanced age. A high index of suspicion is needed for their diagnosis, as they are less likely to present with typical anginal symptoms than younger patients. They also have an increased risk of calcified nodules on top of coronary artery disease. Women's symptoms: neck, jaw, shoulder, upper back or upper belly, the abdomen discomfort, shortness of breath, pain in one or both arms, nausea or vomiting, sweating, lightheaded or dizziness, unusual fatigue, heartburn that feels like indigestion. Another atypical presentation would be diabetics. One of the expected effects of diabetes is the type of nerve damage called neuropathy. It causes problems with numbness, tingling, or weakness in your hands and feet. It doesn't always stop there. It can damage the nerves that lead to the heart, bladder, and blood vessels. When that happens, you may not receive important warning signs like pain or discomfort. During a heart attack, that might generally cause big-time pain in your chest, arm, or jaw. You might not notice anything. Symptoms for diabetics: breaking out in a cold sweat or having clammy hands for no reason. They may have like reading of high blood sugar instead of low, which would confuse them because cold sweats are generally from a low blood glucose reading. Feeling lightheaded, feeling tired for no reason, heartburn, pain in your jaw, neck, or left arm, especially common in women, stomach upset, shortness of breath, even when you haven't done much. Diagnosis of angina and myocardial infarction. So with angina, you have clinical history. You look at the pain characteristics, the triggers, relief with rest or nitroglycerin. Your diagnostic testing would include 12-lead ECG, stress testing, maybe a coronary angiograph, and then blood testing. Myocardial infarction, you're looking for ECG changes, ST segment elevation, T wave inversion. Q waves occur after an MI has happened. We would run blood tests looking for biomarkers like elevated troponins. They have high sensitivity troponin tests, and you do those serial for every 2 hours. For the high sensitivity, it's every 3 hours. You look for CKMB. Imaging, you're looking at echocardiogram, coronary angiograph. So looking at some of these QRS and T-wave portions of an EKG, it has the evolution of the acute myocardial infarction. So on the right, we're just showing the on the right side, we just have a normal QRS. It kind of goes over the P wave. The Q waves are generally not seen until after a MI, and then it'll have a larger Q wave seen over here that we'll talk about. S, so your J point is where the S meets the midline. So you're looking for an ST elevation, would mean that the S bypasses this esoteric line and it would go up, and they would have a large T wave or maybe a T wave inversion. U waves you don't generally see. So we'll go over to A. This is a normal ECG prior to an MI, so no Q wave. The RS wave is fine. The T wave comes up, it's normal. Then you get into the hyperacute T wave changes. So the T wave increases in wave amplitude and width. You might start to see some of this ST elevation. So this is the esoteric line. Here's the elevation over that, greater than 1 millimeter. You go to C, they have marked ST segment elevation with hyperacute T wave changes. So this is a large ST elevation. Moving on, you get to the pathologic, what we call the pathologic Q waves. Right here, the ST segment elevation is kind of going down because you're starting to get the T wave inversion, and that's just necrosis of the tissue. The pathologic Q waves are either greater than 0.041 in duration, which is the size of a small box, or 25% of the R wave amplitude. So that's not quite 25% of the R wave. This is the R wave here, but you would look for the Q waves. Here in E, we have a pathologic Q wave and then the T wave inversion, so you can really not see it at all. And then after the fact, you come up with your pathologic Q wave and upright T waves after the inversion. And that's just the fibrosis. So here you have necrosis and fibrosis, and then fibrosis of the heart. Looking at reading the EKG, you have thin lines, they're 1 millimeter intervals or 0.04 seconds. So that would be a box that's, if the ST segment elevation is at least the size of a box, that's 1 millimeter. Thick lines, these are the 5 millimeter boxes. That equates to 0.20 seconds or 5 millimeters. And then 5 thick line boxes, 1, 2, 3, 4, 5, that equals 1 second. Biomarkers and myocardial infarction. So this is what we would be looking specifically at. Troponin is a protein complex found in cardiac muscle cells that regulates muscle contraction. It also consists of 3 subunits, troponin T, troponin I, and troponin C. Of these, troponin T and I are specific to the heart. When heart muscles are damaged during an MI, troponin is released into the bloodstream. Elevated levels of troponin are particularly high sensitivity troponins and are highly specific for myocardial injury. Having talked to some of the cardiology staff, sometimes having the high sensitivity is not the best because sometimes troponin gets elevated for other reasons, not necessarily an MI, which is why they trend it over time. So this sort of shows 1995 used to have 1.5 nanograms per milliliter. Then they got a little more sensitive in 2003. And now we just look at if it's greater than 0.04 in 2007. And I think the super high sensitivity one is even smaller reading than that. But they do just, you have to trend it, the troponins, to see if they keep going up or if they stay the same or if they go back down. So some people can come in and it might be 4 days after their symptoms start and their troponins have already gone up and they're on the way down. So that's why you would still keep trending them as well, just to see if it's slowly coming back to normal. But it can help identify cardiac injury. It's just when it gets to a certain point, like 4 days after the fact, you're just not going to know. Treatment of angina, pharmacologically, so symptoms, you would have aspirin, 325, 1 chewable, or 4 81 milligrams, which is 4 chewable. They are chewable aspirins, not baby aspirins, because you do not give aspirin to babies or children. So you would do 12 lead EKG, nitroglycerin every 5 minutes, up to 3. So they can do that at home up to 3. We would generally stick to the 3 as well, depending on their blood pressure. Doctors can order to go over that if necessary. Morphine if needed. Some places have switched to fentanyl due to the fact that morphine releases histamines, so that's not very helpful. So nitrates, relief of the chest pain. They just vasodilate, helps blood get around the blockage, and then they start to feel better. Beta blockers, they might reduce the heart rate and myocardial oxygen demand. Calcium channel blockers, they help vasodilate and reduce the cardiac workload. Antiplatelets, sometimes you'll give aspirin or clopidogrel to prevent thrombus formation. Really, aspirin, it's just to make sure it doesn't get any bigger. You're not clot buster or anything, but people are like, oh, I'll give them aspirin and then see what happens. Nothing happens. You just gave somebody aspirin. They're not going to be able to tell if it's working or not. It's just what we do to cardiovascular protective so that the clots don't get any bigger. Statins, that's a lipid lowering to prevent arteriosclerosis progression. Treatment of angina, non-pharmacological, you might have lifestyle modifications, diet, exercise, stop the smoking, weight management. Here we'll talk about the percutaneous coronary intervention. So revascularization, you'll get your fibrinolytic checklist. Would they want to be, on perfusion protocol of a fibrinolytic? So if they're going straight away, they'll still probably put them on heparin. In the meantime, if they're not doing a clot busting, that's generally for a place that doesn't have access to coronary cath service, but most places have them now. So generally, you get PCI is rather quick. If they aren't going to do it till the next day, they'll just heparinize them and give them a bunch of heparin. And then the next day cath them, see if they can stent the blockage. If they can't stent the blockage, then they'll possibly they'll consult with the surgeon and get a coronary artery bypass grafting, which would be the cabbage. So anybody that's had a cabbage, they've taken veins from somewhere else in their body and put it as a bypass for their clogged artery because they can't get either the vessels are too small to get the stents in, or it's just too blocked. They can't bust through it. And then cardiac rehabilitation, you would have exercise, education, and counseling. Treatment of myocardial infarction, you're going to have antiplatelets, anticoagulants, aspirin, heparin, P2Y12 inhibitors, thrombolytics, try and bust up any thrombus. Pain management, morphine or fentanyl. Nitrates, you can give them the under the tongue, sublingual medications to help relieve the ischemic pain, or if that doesn't work, you can do a nitro drip. Just be careful, that gives patients severe headaches sometimes. Beta blockers prevent arrhythmias, reduce myocardial demand. ACE inhibitors or ARBs that reduces mortality and adverse remodeling of the heart. Post-MI management, you would use long-term use of antiplatelet therapy, beta blockers, ACE inhibitors, and statins. Treatments of myocardial infarction, non-pharmacological, would just be, they would have the PCI or bypass graft. Again, you would want to give lifestyle modifications and cardiac rehabilitation. So the biggest thing, patient education. We've done really well with males on this. So if you have chest pain, go to the ER. Most do that. It's different with women. Women have atypical symptoms. Elderly people have atypical symptoms. Diabetics have atypical symptoms. One of the issues with females is they have fatigue. So imagine trying to go to the ER every time you felt fatigued, probably wouldn't work out for anyone in that. Everybody's kind of fatigued. So it's just the biggest thing about recognizing symptoms and seeing your PCP regularly to prevent issues like this. So myocardial infarction. So again, if you believe you're having it, somebody else is having it, call 911 immediately. They can get you start treating you immediately. They can trend the EKG, and then they can also take you to the closest, most appropriate facility that they know will be able to take care of your cardiac issue. The interdisciplinary team, so obviously you would see an ED provider first. They're there to stabilize the patient, administer any life-saving interventions like thrombolytics, antiplatelets, treat your pain. Respiratory therapist, if you had shortness of breath in conjunction with this, they would also be able to help out. Then the cardiology team would get involved. Cardiologist would be a board-certified cardiologist. They may have nurse practitioners or PAs. As someone that's also on the team that would start prescribing you medications, getting you scheduled for diagnostic procedures like EKGs, echocardiograms, stress tests, and then the cardiologists would have them fit you in for the angioplasty or stent placement procedures. Pharmacists, they would do a med rec on you, make sure that they're stopping medications that would be harmful to you during this time period, and then keep you at an appropriate dose for other issues. Again, anticoagulants, antiplatelets, beta blockers, those are all things that the cardiologist and the pharmacist would decide whether or not you should continue, or if they're going to stop everything because they're going to give you heparin and then do if your blood pressure is too low, they'll stop you on your blood pressure medications and all that. Dietitian, nutritionist, you'd be immediately put on a heart healthy diet. So you'd probably be NPO after midnight if you're doing a cath lab the next day, but for the whole rest of the time you're in the hospital, you are on a heart healthy diet and unable to eat just anything you wanted on a general one. Physical therapy, cardiac rehabilitation specialist. They're going to, after the procedure, make sure that you're regain your physical strength and endurance and make sure your heart gets back up to the healthy part. Primary care provider, you're going to see them up as a follow-up. You'll also start seeing cardiology, but your primary care provider will learn about your diagnosis or your risks, and then continue to help you on your journey to get healthier. And these are the references.